Persons, good afternoon, dear colleagues. We'll talk about the emergency embolization of ruptured bone tumors. We are all, as interventional radiologists, we are familiar with the emergency embolization in cases of GI bleedings, in case of hemoptysis even. But sometimes the large and expansile bone tumors carry a risk for embolization, a risk of rupture, and they may need embolization. The large, the very expansile, the rapidly growing, the highly vascular bone tumors are prone to rupture, either spontaneously, accidentally, or by a trauma. And in these cases, we can imagine a patient presented with acute swelling or acute pain or even blood loss. The orthopedic surgeon is confused. What can he do? The lesion is very vascular, is supplied by has a rich blood supply, and therefore the role of interventional radiologist will come here to do emergency embolization in such tumors. Some of the very common bone tumors carrying a high risk of rupture, either accidentally or by trauma, are the aneurysmal bone cysts, the giant cell tumors, the hemangiomas, especially in the spine, the rapidly growing osteosarcomas, the Ewing sarcomas, and the large osteoblastomas, and some of the highly vascular metastases. So the patients, as we said, present with acute swelling or acute pain or even blood loss, loss of joint or limb function, and sometimes in the lesions which are close to neurostructures, the patient may present with emergency neurogenic symptoms, especially in cases of ruptured tumors of the spine. So the primary aim, of course, as in all cases of emergency embolization, is to stop bleeding and to save the life of the patient, and then after that to relieve the pain and neurogenic symptoms, to restore the limb function, and to induce tumor necrosis, and then if the surgeon is planning for surgery, is to help the surgeon to perform a safe surgery without excessive bleeding and without the need of excessive transfusion, of course, in the operation. The most important to need, the nightmare of embolization for all interventional radiologists is the non-target embolization. We are always afraid to hit an innocent artery that is not supplying the lesion and that is supplying some other important structures. So the most important thing to do is to perform this embolization in a well-equipped angiography suite. And I mean by well-equipped, an angiography machine that is better to be high-end, having very important specifications. And it's better to perform this embolization with a machine having a cone beam CT or a CT angiography to be sure that the artery to be embolized is the artery supplying the tumor. Of course, all types of catheters should be available in the angiography suite, the mother catheters, even the micro catheters, the guide wires, and all types and sizes of the embolic agents should be available, because sometimes we may need different sizes of particles of embolic agents to supply different types of, to embolize different types of tumors. As we said, the nightmare is the non-target embolization. We are all familiar with the GI vessels in emergency GI bleeding. We are all familiar with the bronchial arteries in case of hemoptysis, other arteries. But in case of ruptured bone tumors, the limb arteries, the pelvic girdle arteries, the spine arteries are not only supplying the tumor, but they may supply other important structures, especially the spine arteries. They are supplying sometimes the spinal cord. We do not want to save the life of the patient from embolization, but end in neurogenic complication or in paralysis, for example. This is an example of spontaneously ruptured giant cell tumor of the lumbar spine, and we were challenged by an emergency embolization of the supplying arteries, and here we find the crowd of arteries, many arteries supplying the tumor, but not only supplying the tumor, some radicular branches arise from these arteries and supply also the spinal cord. We have about 5 arteries which are the target arteries to be embolized. Each one of these arteries should be super selectively catheterized better using a microcatheter, and embolic agents, appropriate size of the embolic agents, are to be injected. And this is the picture after embolization. The crowd of arteries, the blush of arteries disappeared, and the lesion had been excised after that safely without excessive intraoperative blood loss. So it's better to perform, if we're not in hurry, it's better to perform pre-embolization CT angiography to detect what is the exact artery to be embolized. If not, we can perform cone beam CT during the embolization process to be sure, because sometimes the arteries deceive us. Okay. So this is, for example, an example of ruptured aneurysmal bone cyst of the sacrum, and we performed pre-operative CT angiography to detect the target artery to be embolized, which is branches of the external iliac artery, namely the lateral sacral artery. As we can see here, there is a crowd of vessels. Sometimes we can get confused. What is the exact artery to be embolized? We can perform angiography in the AP position and then in the lateral position, in the oblique position to detect what are the arteries. But in these cases, cone beam CT will be very helpful to detect that we are in the target artery to be embolized. Here is, for example, we have catheterized the suspected artery, and we performed cone beam CT before embolization, and then we can see that the artery supplies the target tumor to be embolized. The embolic agents, I prefer to use the 300, 500 micrometer particles because, as we know, the smaller particles can trickle into some innocent smaller vessels and result in non-target embolization. I do not prefer to perform gel foam embolization because sometimes it's a temporary embolic agent and sometimes the surgery is delayed for a reason or another, so the patient might need another session for embolization if surgery is planned. Let's see some of the cases. This was a 14-year-old volleyball player presented with acute low back pain after ruptured sacral aneurysmal bone cyst. And this case, the surgeon referred this case for preoperative embolization, and we agreed to perform embolization using particles as the operation will be planned after 1 week from embolization. This was the ruptured sacral aneurysmal bone cyst, and this was the preoperative angiography, external iliac artery, and the lateral sacral artery was the artery supplying the lesion. This is the blush of the aneurysmal bone cyst, and super selective catheterization of this artery using a microcatheter was done, and then we performed cone beam CT to be sure that this is the target artery, and then we performed embolization using 300, 500 micrometer embosphere particles. However, after a week, when the surgeon decided to do the operation, the patient refused because the acute pain had totally disappeared. So the patient and her parents, they decided to postpone the surgery for a little bit. 1 month after another, the patient noticed that the pain totally disappeared. So the surgeon decided to postpone this surgery and to follow up the patient every 3 months. This was the use of cone beam CT. This was the post-embolization. The artery supplying the lesion, the lateral sacral artery from which the supplier of the lesion arises, has been totally blocked and amputated, as we can see. Surprisingly, after 12 months of embolization, the patient had no recurrent pain, and this was the cortical formation, new bone formation around the lesion. This was the result after 12 months, and the patient didn't go for any surgery after this. This was another 16-year-old male patient presented with acute back pain and left lower limb acute pain and weakness, and the lumbar sacral spine MRI diagnosed ruptured L1 hemangioma. This was the ruptured hemangioma compressing the spinal canal posteriorly. And in this case, emergency embolization was performed. The arterial supply of the lesion was attacked, and this was the blush of the ruptured hemangioma. As we can see, the whole vertebra can be shown by the ruptured blood vessels. And the artery of the opposite side, the right and left arteries, were attacked, were targeted, and they have been embolized. The blush has disappeared after embolization. The pain started to disappear after a few days. The patient underwent a safe, bloodless surgery, and cementoplasty was performed with fixation of the spine. This was a 17-year-old hemophilic patient. Unluckily, he had ruptured lower limb osteosarcoma after an accidental trauma. This was the MRI of the ruptured tumor, and he was sent for emergency embolization. This was the arteries supplying the lesion arising from the femoral and popliteal arteries. Many arteries were supplying the lesions, and all arteries should be targeted for embolization. And in the same technique adopted nowadays for the genicular artery embolization, we perform selective catheterization of each artery supplying the lesion, followed by particles injection till total disappearance of the blush is achieved. So this was the pre-embolization blush of the large osteosarcoma, and this was the post-embolization bed that is now more than 70% or 80% clear from any vascular, any abnormal blush. So in conclusion, the transarterial embolization is a life-saving and acute pain-relieving interventional procedure in case of ruptured MSK tumors. And the specific benefit is present where there is a high risk of spinal involvement or neural encroachment, where active bleeding is present, or in awkward surgical locations where delayed or prolonged surgery is anticipated. And again, we should be well equipped, we should be super selective, and we should make a good choice of the embolic agent and their sizes to avoid disastrous non-target embolization. And thank you.